through Whova, okay? You won't be able to do that here in Zoom, but you will be able to do that in Whova.
Make sure, did you already?
All right, Robin and Amanda, I see you both here. You both have your spotlight and your co-host permissions. Okay, for ASL interpreting. Kenton, I see you are here. Got yours set up. Candace, I see you're here. I gave you some co-hosting permissions. And when you're ready to turn your camera on, I can spotlight you. And let's see. Let's see, Iris, I see you. I'm gonna make you a co-host and make sure your Spanish language interpretation is on.
Thank you very much.
Thank you.
Appreciate it.
All right. Yes, we appreciate you. All right.
Where's the button? I'm sorry. Where's the button to hit on? Let me see. For Spanish. Okay, I think I may have it. Could you please check, make sure that I hit the correct button for a Spanish interpretation?
Hi, Iris, it's Tiffany Clayton. What you'll need to do is go down to the very bottom of your screen and there's a globe looking icon that says interpretation.
Yes, I did that.
Awesome.
Okay. Iris, I think I need to add you in for this one.
Okay.
That was me. Okay. And let's
because usually I get a bar.
Okay. Now you should have that.
Okay.
Hi, everyone. Welcome. We'll go ahead and kick things off since we are right at the starting hour at 12:30. My name is Tiffany Clayton. I'll be your brief host for today. I'm here on behalf of Phoenix, which is a nonprofit here in the Huntsville area that works on catering to those with disabilities, breaking down those social barriers, and also improving their quality of life. Now, as I mentioned, I'll be your host, but you guys are not here to see me today. We've got a great panel ahead of us today that has some presentations to talk about this pandemic that we're in, and of course, the big elephant in the room, COVID-19. So what we're gonna do is we're gonna start with having them present themselves, and they do have information and presentations, and we'll save questions towards the end. If you guys have any questions or comments, we're currently in Zoom, but again, direct those comments to Whova. That's where I'll be reading them, and we'll be feeding that into our panelists. But without further ado, we'll start with Mr. Neil Lamb. Feel free to introduce yourself, and we'll roll into Kyle and continue with the presentation.
Good afternoon, everybody. It's a real pleasure to be here, and I thank you for the invitation. My name is Neil Lamb, and I lead the education program at the Hudson Alpha Institute for Biotechnology, which is here in Research Park. And I'm a trained human geneticist, and right now I'm spending a lot of my time talking in everyday language about COVID-19 and separating fear from fact and answering lots of questions in the community and creating a set of videos. And I'm looking forward to our conversation about COVID-19 in everyday language.
Thank you, Neil. Kyle, feel free to introduce yourself.
I think we may have just lost Kyle. I just saw him disappear from the screen. I'm sure that this never happens to anybody else that's watching us. Nobody else has ever had any Zoom issues.
I'm back. I'm so sorry. I went.
No, that's okay, Kyle. That's okay. It's the joys of technology. The joys of technology. So feel free to chime in when you're ready. Oh, sorry, Kyle will need you to unmute yourself. There you go.
Okay. Good afternoon. I'm excited to be a part of this discussion. We healthcare folks, especially hospital leadership, has been very engaged in providing support to each other through what we all will look back on at the end of our careers as one of the most challenging time periods, definitely that we've ever experienced. And really a situation in which we've learned more about ourselves and our community than any other point in our history, for sure. Can you all see my screen there with Helen Keller Hospital on it?
Yep, we can.
Excellent. So I'd like to talk a little bit about where we were prior to COVID, and discuss the experience of diving into a historic pandemic, some of the things we've learned, and quite frankly, some of the things that we have not done well, and how we as a community can move forward to address some of those shortcomings that we've identified. So before COVID, and we like to call it BC. So in the lifespan of our hospital was 100 years old last month. So we have this lifespan of 99 years, and then last year. So prior to March 24th of last year, we, like many hospitals, were in growth mode. These bullets highlight some of the focus areas. Again, just from a classic perspective of leading hospitals during a time of growth. These are the typical types of things that we were looking into, as well as the hospitals across our state and in the Southeast particularly. And these are photos and celebratory items that we really were looking forward to up until March 24th of last year. So we're a small hospital. We are based in the Shoals. Our hospital straddles the municipalities of Tuscumbia and Sheffield, Alabama. We are a 185-bed facility, which also responsibility for a 25-bed community access hospital in Red Bay Hospital. So we're a small outfit in a relatively small area. We take a lot of pride in doing what we do well, and then have sister hospitals in Huntsville and other partnerships with UAB and Vanderbilt to take care of higher acuity patients. But we do a lot of work. We're largely a $150 million outfit. We take care of upwards to 15,000 to 20,000 patients a year. And throughout this time period, really stretched a lot of our resources. So I will never, for the next 80 years, forget the phone call that we received on March 24th at 9:18 p.m. We had been, at that point, preparing for 2 months to care for COVID patients, and thought we had it figured out of how we would address our first COVID patient, and we thought would be in a 90-ish day time period of this pandemic. And what we found was very different. So our first patient arrived on our doorstep with a non-classic case. So it was an 80-plus-year-old white male who had tested negative at a neighboring facility. They could not pinpoint what his diagnosis should be and were concerned about it. We asked if they would send the patient to us, and we'd take another look. Upon consideration for that patient's symptom set, who had no fever, did not show what was then the classic symptoms of COVID, we thought we'd do a secondary COVID test to make sure this wasn't indeed our first COVID patient. And at 9:18, the test resulted positive. Since then, we have cared for 1,114 COVID positive patients in our ER. Several of them transitioned to our inpatients, in which we had 834 COVID positive inpatients. In no universe did we think, again, as a small community hospital, that we would care for that many patients with one disease. I tell people all the time, when we had the conversations in the community very early, and many people said, oh, it's not a big deal, Well, I said if we have 50 patients in Helen Keller Hospital who were dying from AIDS, we would consider that a serious deal and would do everything we could to protect each other from an AIDS outbreak. Well, this is a very different disease that, quite frankly, is hundreds times more contagious. And we found, of course, as we have very transparently across our country, that it can be just as deadly. And worked through that and learned a ton in the process. So some of the things that we learned were that the science behind where we were and where we wanted to go and how we wanted to protect ourselves and our community and our patients was largely based on PPE. And 3 years ago, we laugh now, if you had mentioned the acronym PPE in public, most people wouldn't know what that meant. But we in hospitals have long leaned on protective personal equipment and found that it was hands down a much more effective way to protect ourselves than we thought. We've calculated at this point, based on the number of staff interactions per patient, which each of these almost 2,000 COVID positive patients we've interacted with, several of them being here for multiple months, some being here for a few hours in the emergency department. But we estimate that over 400,000 staff interactions have occurred. So that's every time a member of our team has interacted with a COVID positive patient, sometimes several dozens of times during a shift, sometimes just once during the patient's stay. And with those, we have identified 6 direct COVID staff infections. So there are 6 people who we know, due to the circumstances, contracted COVID due to a direct patient interaction. 124 people on our team became COVID positive at some point during the pandemic, but we attribute it elsewhere. So they had a family member at home who became positive, and the next week they became positive. So we think that is the factor that led to their positive outcome. But yeah, that's 0.03 infection rate. We have, just to put that in context, we've heard of situations, and all of us have, when last winter we had several family gatherings and others that we held on to later to say, hey, 14 people in that went to that family dinner for Thanksgiving, 12 of them became COVID positive. And I know specifically of a Sunday school group that had a dinner in which all of them wore masks and tried to take the necessary steps to protect themselves. But one of those gentlemen was COVID positive and extremely infectious. And every one of the other 10 members of that Sunday school group became COVID positive. So to have an infection rate of 0.03 with known COVID positive patients was exceptional. And we take a lot of pride in several of the steps that were difficult to make, but ended up protecting ourselves. Second lesson we learned was our local community. We found new strength and agility. So historically, when we think about last January particularly, healthcare providers were at our max capacity. And I'll just use our hospital as an example. There were several days in which we teetered on the edge of being able to accept more patients. That we tend to get at that point at about 135-ish patients is pretty much a full house for us. We stayed there for weeks and found new ways because the fact that others were in that same situation. So when Huntsville Hospital and UAB and Vanderbilt and others are just as full, typically a patient who we would transfer out when they reached a certain level of acuity or need some subspecialty help, we had to find a way to take care of here. We had to get on the phone with that physician at Vanderbilt at 2 o'clock in the morning to say, hey, doc, this is what's going on. I know you guys can't accept patients, but we're wanting to make sure we take care of Mrs. Johnson the best way we can, given that we don't have a place to send her. So that going through those situations together and connecting with other healthcare providers really is something that we want to take beyond the pandemic. Also, community-wide independency. I've never had phone calls from local mayors to say, hey, we're coming off of Christmas and we're considering rec league youth basketball. Is this a good time to do it, or should we put it off for a month? And I would share our data to say, Mayor, I think it's probably wiser to delay it for some time. and working together with all of the community partners, even those outside of healthcare and depending on each other, is another element we'll take forward. Now, this is what I really, this is a layman's take, so to speak, but I really geek out over this stuff. So you guys flag me down if I get too into this part of it. But we often hear the term of new normal. There will never be what we consider normal in healthcare again, period. Coronavirus and this pandemic has been as much of an inflection point in the lifespan of healthcare as, and this is, I put this on the same tragic level, but as the tragedy of 9/11 was to air travel. Just like air travel before 9/11 was very different from air travel now, the same will be the case for healthcare. We will seek services differently. We will go about producing those services differently. We will market our services differently. We will recruit different healthcare providers to our communities differently. I mean, everything about what we do will be either slightly or drastically different after COVID. Two, protection is critical. Our vaccination, we'll talk a little bit more about that, is absolutely paramount if we want to move beyond this pandemic. Our flu season or lack thereof is a very important gem that we're taking from this pandemic. So essentially we, through January and February of any given year, would come in contact with 10 to 12 COVID patients a day through our ER, through our surgery departments and other areas in our small community. This year, from December to February combined, we saw approximately 15 flu patients. We literally had no flu season this year. And it wasn't because of a lack of testing. We still test the same people who have the right symptoms upon presentation. We just literally didn't have any positive cases. And so after I think the dust settles a little bit after, of the vaccination effort, we will continue to look into what exactly happened with flu season. Yeah, we had a historic pandemic, but we also had a historically low level of flu, and flu is also can be a traumatic disease for elderly individuals. So what happened to make that disease disappear this year? Opportunities. So this is where I kind of fall on the sword and say, you know, what have we not done well? And all of these fit into a few broad categories I think speak directly to the point of this session. One is Medicaid expansion. What has become blatantly obvious is that our state is one of very few who did not expand Medicaid. Hospitals across Alabama have been advocating for Medicaid expansion for years, and it exposed us some. So there are approximately 250 to 300,000 people in the state of Alabama who earn too much to qualify for Medicaid. Medicaid in our state covers the federal minimum. So there are lots of people who don't qualify, especially working adults. But there, of course, are that number of hundreds of thousands of people who don't make enough to afford commercial insurance. That group of people is the specific target of Medicaid expansion, which was a part of the Affordable Care Act. We, in our state, chose not to do that. We have some renewed interest in Montgomery, I understand, based on the pandemic, also based on the CARES Act fund, which makes it more affordable for states to take a step in that direction. We have to expand Medicaid. When those individuals who go to work every day and who have in the past 3 months have contracted COVID and are out of work for several weeks, who are in the hospital for several weeks and have no way to cover those bills, particularly their healthcare bills, that takes resources out of our economy, tremendous resources out of our economy that could be available for them. Numbers 2, 3, and 4 are mental health, mental health, mental health. If we thought we had a mental health crisis before COVID, we are woefully unprepared to handle what many of us think is heading our way. We have seen the data, and we see every day, particularly among adolescents, that our mental health resources are number one, in many ways, not expanded and not as robust as they should be due to a lack of funding primarily. But secondarily, still reeling from the pandemic. So we have mental health centers that are limited as far as what they can do with COVID positive patients, and others that that are just not in position to be able to do everything they want for their patients and for our community. And until we find the appropriate ways to fund them fully and truly address mental health in our state and our communities, that's going to continue to be something that plagues our areas. Then also disparities, and I'm hoping this link will work. Let's see here. There we go. All right, so I have taken the liberty of moving away from, can you all see that, the CDC site? Thumbs up, someone.
Yep, you're good to
Yes.
go, Kyle.
Excellent, thank you. So we think about health disparities. Often we have confusion, and I don't mean this in a negative way, but often have confusion about what that means and where, how to quantify that. And so I thought we would take a bit of a spin through the national database that the CDC holds, that's fairly robust, to share what is a true health disparity when it comes to COVID, and let's quantify that. So in Alabama, you'll see here the adjusted COVID-19 deaths, population distribution by race, and Hispanic origin. So you see non-Hispanic whites here, 65.3 blacks. And this is the unweighted distribution of the population. Let's see here, 26%. And then you see the information that it flows. None of this should surprise us. We all know the percentages of these demographic areas in our communities, as well as the fact that many of the COVID-19 deaths were centered on communities of color. But this is what I think really stood out to me. We'll zero this in on Alabama as well. This should bother everybody, especially when we think about this conversation. So the differences between, I'll just read this, differences between the percent of COVID-19 deaths and the population distribution by race and Hispanic origin, the impact of adjusting for age. So what this shows is that for in Alabama, and values around 1 or less mean that the rate of COVID-19 death mirrors that of the greater population. So in our state, you see that folks of Hispanic origin, non-Hispanic American Indian, Alaska Native, non-Hispanic Asian are largely near the center. And then you see where here in the Black community, large disparities to say that if you adjust for age, so adjusting for age means, of course, that an 85-year-old we realize is more likely to die from COVID than a 19-year-old. So this begins to account for that. You see this drastic negative disparity here in the Black community, and a equally almost drastic positive disparity in the white community. This shouldn't be. When you think about who we are, and as a healthcare community, who we are as a greater community, we should not have large gaps in care that result in this type of disparity. We should largely be around the center. This shouldn't exist. And this should be something, and it is something that keeps healthcare leaders up at night. And you see it across the board. We take it, we'll take 0 to 10 on Alabama as well. The same disparities. When you stratify by age, you'll see those same categories showing these large disparities. And the disparities are larger when you look at younger folks. So, and I kind of put this in a couple of sentences. So younger African Americans have a higher disparity when it comes to death due to COVID-19 than whites, drastically larger. This is a problem. Going back to Alabama. So we saw those drastic disparities when it came to death. We also have equally concerning data when we come to vaccines. And it's an ongoing effort. We just had last Monday, every adult above the age of 16 became eligible to receive vaccines in our state. Most states have moved in that direction. But the data concerns us, and I'll show you why. One, on this, you see the large, high level assessment, and this is just Alabama only. It shows for our age groups, those that have been vaccinated. You have your 75 and up here on the top right, 70 to 74, and then 69 and below. One can say at a glance, this is not near where we should be. The 75 and up category has been eligible for vaccines now for 2 months, and we've only reached 59%. That's our most vulnerable population. We're not even close to being where we need to be, which is 70 to 80 to 90%, especially for that population. My wife likes to point out the bottom right graph there to say that women in Alabama are smarter than men. I don't know that I completely disagree with that. But again, that's a pretty large gap for 22% of the total population in the state of Alabama to have received vaccines and only 16% of male. You would hope that that would be a little bit closer, that men would be closer to that 20, 21, 22 percentage. And yes, that is an indication, I think, of intelligence to some regard. But here's where, again, this is what keeps us up at night. So we think about what we've been through over the past year, as I indicated earlier. You think about the communities that were impacted by COVID, and then what's going to prevent us from going back there. So this top right graph shows you, and I'll just run down the list, that 16% of eligible Asians in Alabama have received the vaccine. 11.9% of African Americans have received the vaccine. 15.5% of eligible whites have received the vaccine. Y'all, that's not nearly enough. At this point, and again, we're in the first week of April, vaccines have been available for 3 to 4 months, depending on your category. These numbers should be close to the 30 and 40% for each category. And again, we're not even close to being at that point. So our concerns going forward are that without that type of vaccination uptake, that we are could find ourselves in the position, if not a large surge like we had in January, that we could see a much slower eradication of COVID than we think possible. And with a large vaccination effort across our state and everyone lining up to get the shot, so to speak, we could see that become less of a problem much sooner. Are we entertaining questions at the end or now?
So Kyle, what we're going to do is we're going to have questions towards the end because we're going to roll into Neil's presentation.
Excellent. Thank you.
Thank you, Kyle. Again, everyone, that is Kyle Buchanan representing Helen Keller Hospital. So next we have Neil Lamb. He's the Vice President for Educational Outreach, and he's here on behalf of Hudson Alpha Institute for Biotechnology. Neil, feel free to take it away.
Thanks, Tiffany. And again, hello, everybody. So I'm really glad that Kyle went before me. Number one, he did a great job laying things out. And number two, I get to say, Kyle, thank you so much to you and your colleagues in the healthcare system. I know that this has been an unbelievable experience, but you have saved lives and have worked so hard to keep our communities healthy. And I know I speak for everybody on the call just to say thank you, and to thank you to everybody else who's on the call who works in healthcare. So I'm going to lay a little bit of additional groundwork of kind of all right, here's a snapshot of where we are as it relates to the pandemic, and where are we potentially going, and what are the things that keep me up at night, many of which are the same things that you've just heard from Kyle. So this is a look from in the Huntsville metro area, the daily new cases of COVID per 100,000 individuals. And so this goes all the way back from the beginning. And you can see the summer surge, and then we kind of dropped back down some, and then you see that huge fall and winter surge. We're at a place right now where we're at about 6.4 cases per 100,000 people in the Huntsville metro area. That's about 30 new cases a day on a 7-day average. And that is definitely much, much better than where we were earlier in this year. We would like to see that number continue on that downward trajectory. I recognize that as you look at this, some of you are automatically thinking about where you were in different places where those curves peak or where those curves drop. And I realize that some of us on this call have stories of our own selves getting COVID or our loved ones, and maybe even stories of grief related to this. So I apologize if looking at this brings up memories. The point I want to make from this, number one, is how very grateful I am that we are at a lower number. And that's because of the role of our community. That's because we have taken the time to practice distancing, to continue wearing masks, to stay home when we don't feel well. Other parts of our country are not seeing a curve that looks like this. Michigan, for example, they are in their 4th wave. They are seeing a huge increase. And in large part, that's because the variant that was first identified in the United Kingdom, scientifically, that's B.1.1.7. You don't ever have to remember that. But that variant is surging. It is driving those numbers. And it is about 60 to 70% more infectious. It's about 60% more lethal in terms of more serious side effects. And again, the numbers that Kyle showed you, I'm thrilled that we have as many vaccines in arms as we do, but a huge percentage of our population still don't. And those are the people that are now even more susceptible to a version of the virus that spreads even easier. So we've got to watch for that. Here in Alabama, we're seeing somewhere between, around 20% of the cases that we're doing genetic testing on that are actually coming back as being in that UK variant class. So we've just got to watch those numbers really carefully and that we don't find ourselves on the upsurge again. We also have, Kyle's talked about vaccines. I think many folks in this audience know, but it's worth saying right now there are 3 vaccines that have emergency use authorization across America. So that's the Pfizer BioNTech and the Moderna. Both of those are mRNA vaccines. They use a small piece of mRNA, a chemical recipe that tells your body to make, in this case, the spike protein, which normally sits on the outside of the SARS-CoV-2 virus. And then that spike protein shows up on the outside of your cells that have been immunized, and it triggers your immune system to say, I don't recognize this. I need to build an immune response. Those are 2 doses. The first dose primes the immune system. The second dose really kicks in the stronger immune response. 21 days apart between the 2 doses for Pfizer, 28 days apart for Moderna. And then the newcomer to the field is the Johnson & Johnson vaccine. And you might also hear this called Janssen, because Janssen is one of the makers, one of the subsidiaries of Johnson & Johnson. This one doesn't use mRNA. It uses a piece of DNA and a modified virus to get that genetic information into your cells. And the same thing happens. You use that genetic code to make the protein, sits on the outside, triggers your immune response. That only requires 1 vaccine. It's a one and done shot. And then the other thing is that there are lots of numbers in the bottom of this slide. And I don't want you to get hung up on this because we cannot play bake-off. We can't play head-to-head bake-off on these efficacy numbers. The numbers are high for Moderna and Pfizer, and they're very, very acceptable, but they're less high for Johnson & Johnson. They didn't all use the exact same definition of what qualified as a case of COVID. And Johnson & Johnson was actually running their trials at a time when we saw more of these variants that we didn't see. We were dealing only with classic COVID with Pfizer and Moderna. The bottom line, all 3 of these vaccines do a really good job at keeping you from getting seriously ill if you get COVID. Now, it's not 100%. There are still people that get vaccinated and then come down with COVID. They're exposed and they get infected. But by and large, it's a much less severe version of COVID. You see many, many fewer people in the hospital or on ventilators. Now, if we look at the Madison County vaccine data, Kyle was showing you the data for the state of Alabama. I'm going to dive down just into Madison County. This is from the Alabama Department of Public Health. You can go to their website and you can click on the state level or the county level. This actually shows you that 140,000 doses of the vaccine have been administered in Madison County. I think this data was through Monday. And you can see the blue curve, the blue lines, the blue graph, the bar graph, that's the number per day. And you can see that we do more vaccines during the week than we do in the weekends. That's why those bars are much lower, especially this past weekend with the Easter holiday. So you can see that we're increasing, but again, just as Kyle mentioned, if you look at this, and I recognize this is small, so I apologize. Let me just walk you through it. On the left-hand side is of those doses that have been administered in Madison County, what percentage of those doses have gone to groups with different races? So that red part of the donut, that's 61% of those vaccines have gone to Caucasians. 15%, that's the green part, that's gone to individuals who self-identify as Black or African American. And then that blue piece, that's about 20%. Those are people who have not reported a race. If you then shift over to the right-hand side, this correlates with the graph that Kyle showed you of all of the people that are eligible for vaccine in Madison County at a different ethnicity group. What percentage have already had a vaccine? And so you can see that, for example, 26% of people that self-identified as white have had the vaccine versus 18% that have self-identified as Black or African American that have had the vaccine. So as Kyle has said, this is not enough. We have got to have more people getting vaccine. And I know part of that is because it's been unavailable for large swaths of the population until now. As of now, anybody who's 16 and older can get the vaccine. If you're 16 or 17, you can only get Pfizer, not Moderna or Johnson & Johnson. But there also is a real challenge in how you find access. The websites are tricky. They're challenging to navigate. You need to be able to look in multiple different counties, or you need to be able to look at places like Sam's and CVS and Walgreens. And some folks don't have access to that level of internet activity, the ability to be there. They may not be internet savvy, and they might not be able to spend as much time online looking for vaccine as you need, or they may not be comfortable knowing how to navigate their way through this. That's a real issue that we've got to look at. Forget people who have vaccine hesitancy. People who want the vaccine often have a hard time figuring out how to get it and where to go. All right, I'm going to transition for the next few minutes, and then I'll hand the reins back. I have created about 70, maybe not 70, 65, 68 videos on my Shareable Science blog, Shareable Science Beyond the blog, that talk about COVID-19 in everyday language. It's me and a whiteboard, and these are 7 to 10 minutes long. And a lot of people submit questions. And here are the questions that I am seeing a lot over the last several weeks that some of you in the audience may be asking as well. The first is, do vaccines prevent the spread of the virus, or do they just protect against serious illness? The clinical trials were specifically designed to ask if the vaccine prevents serious illness. That's what they were developed for. Scientists all along believed that these vaccines would also slow the spread. So if you were exposed to the virus and had been vaccinated, it wouldn't take up residence in your respiratory passages. Or if it did, it wouldn't be at a level that you were likely to transmit. We thought that all along, but that's not what the clinical trials tested. Now that you've got millions of people that have been vaccinated, you are able to assess that. And it looks like that all three vaccines are in the 80 to 90% efficacy at preventing transmission. So that's fantastic. Not only do they keep us from getting sick, they also keep us from getting an infection and from passing it on. Are vaccines effective against the variants? So a variant is just a set, it's just a type, it's a version of the virus that has a combination of genetic changes. Viruses mutate all the time. It's part of their process. There are a handful of these variants that the Centers for Disease Control have classified of concern. In other words, they're tracking them closely, and they believe that these mutations have given them some new property, the ability to spread more quickly, or the ability to be more lethal, or the ability to evade the immune system. I told you about the UK variant. It's one of those under concern. You might also know the variants that were first identified in South Africa or in Brazil. Those are really the top 3 that are being looked at. Fortunately, all of the vaccines that have been authorized in America are effective against all 3 of those. They're almost completely effective against the UK variant, which is good because that's become the dominant one in the United States. They're slightly less effective against the variant identified in the UK, in South Africa, and in Brazil, but those vaccines have a buffer built in. So even though they've dropped in efficacy, that buffer keeps them above the level of being effective. So the short answer, I talked way too long. I apologize to our sign language interpreters who are having to keep up with me on this. The short answer is yes, they are effective. Next question, how long does protection last? At this point, we know that the vaccines provide protection for most people at least at 7 months out from vaccination. And we know that because it's been approximately 7 months since we enrolled all these people into these clinical trials last year. That doesn't mean that we expect that at the end of your 7th month, you suddenly have no immunity. Every month past when we started those clinical trials, we continue to assess. And I think a lot of people believe that there'll be immunity out to 12 months and maybe even longer. Not everybody has the exact same immune response. We know that people that are immunosuppressive, for example, that have had a kidney transplant or a liver transplant, it looks like they are mounting less of an immune response to the vaccine. And we know that some people seem to have a slightly lower response. But in general, the data suggests that most individuals mount a really strong, consistent response that lasts at least at 7 months. And if we're going to go with the Energizer Bunny, 7 months and ticking. So we're still measuring that out. Can vaccines be given to fill in the blank? Lots of different groups. Can they be given to children? Right now, if you are 16 or 17, you can get the Pfizer vaccine, but no vaccines have had emergency use authorization in America for younger than that. Both Pfizer and Moderna are in the middle of testing clinical trials for individuals 12 to 16. And so that younger teenage audience. I expect, we've seen some early data that's really, that is promising, that says that it is protective, that we don't see side effects. I would bet that as we move into the summer, you're going to see teenagers become approved, at least under emergency use authorization. Now, children, they're enrolling the clinical trials now. And I think we will probably not see anything about that until maybe late this summer or even early this fall. So it's possible some children will be vaccinated in time for school, but I really think we're going to be dealing with that a little bit further out. And then I already told you about immunosuppressed individuals, that they are eligible but seem to mount a lower response as long as they haven't just received their transplant. They want to wait for that. And then the data around pregnant and nursing women, these groups were not included in the clinical trials, although animal studies did not find any issues with fertility or with birth defects. There were dozens of women in the clinical trials that got pregnant as they were enrolling or participating in clinical trials, and we didn't see any issues. And Pfizer has just announced a 4,000 person clinical trial for pregnant women. The American College of Obstetrics and Gynecologists have said that women who are pregnant who get COVID are at a higher risk of complications. And that's something that Kyle probably can speak to much more appropriately than I can. But because pregnant women are at a higher risk, they have encouraged pregnant women to consider being vaccinated. But again, we're still waiting on some additional data to come back on that. And then the question that I probably get asked most of all, are the vaccines safe? And I would say vaccines have one of the highest bars for safety of any medicines that are approved in America. There are somewhere in the neighborhood of 80 or 90,000 people that have gone through clinical trials of the three emergency use authorized vaccines in America. And we know that there are symptoms, side effects that appear within the first 24 hours for many people: pain in the arm, swelling. Some folks develop a fever or chills or muscle aches or fatigue. These generally don't last beyond about 24 hours. We know that there are rare side effects that happen, 2 or 3 people per million or less. Anaphylaxis, that extreme allergic response. That's part of why we wait 15 minutes after you've gotten the vaccine, and all the places where you can get the vaccine are equipped to deal with that if you develop that allergic response. And we're continuing to gather data looking for other really rare side effects. The piece I can't answer is, what about long-term? Tell me about what happens 2 years or 3 years or 4 years. We don't have that data. The people that got the vaccine early on in phase 1 trials have had the vaccine for a year at most. But I can tell you this, if you look at all other vaccines, very rarely do you see side effects that show up after those first 24, 36 hours. But when they do, they're all within a 2-month window, within 8 weeks. That's a big part of why the FDA required 8 weeks of assessment for patients after they'd gotten vaccinated. So we don't have any data that would argue that we would expect to see long-term side effects. That doesn't mean that it's not there. None of us can promise that, but based on all the work that's gone into all these vaccines, and even mRNA vaccines, the new players on the scene, we've got 20 years of work in the development of those. So none of these are, I developed this on, March the 1st out of thin air, and now suddenly it's in people's arms. I recognize we all have to look at risk differently and measure out those risks, but it's important to measure that out from a place of information. So I think that's the end of my piece. And Tiffany, I will turn it back over to you.
Neil, thank you. Thank you so much for your presentation. At this moment, everyone, because we're here until 2 o'clock, we're going to start turning it over to you guys. We're going to leverage this as an opportunity for the community to speak directly to, the healthcare professionals that we provided today. So Neil and Kyle, while you guys were talking, we had a poll that was going on in the chat, and I want to share some of those results with you guys. I think you guys might be happy to see what's going on. So the poll that we had was asking participants, do you have concerns that will prevent you from receiving a COVID-19 vaccine? I know with both of the presentations that you guys shared, the numbers were a little low, but I'm happy to say that so far 71% of the people that responded said, no, I already have and or plan to receive the vaccine. So you've already got people that are in here ready to just follow suit. So we're going to switch to the chat and the questions. So folks, again, we're here till 2 o'clock. If you have any questions that you'd like to submit, feel free to go through Hoover. That's where I'll be able to monitor the comments and the chats. Now we're also, Amy, correct me if I'm wrong, allowing folks to raise their hand and also ask the questions directly. So you've got 2 ways to interact with everyone, okay? Alrighty, so we're going to take a look at one of our first questions. You guys both mentioned that, as we saw, the numbers are very, very low in terms of who's receiving the vaccine. So Kyle and Neil, are there any suggestions that you have to increase those numbers?
Kyle, do you want to start, or do you want me to take a stab at that? All right, I'll go on ahead. I'll jump in. So I think one of the best things that we can do to increase those numbers is to have conversations like this, where people can ask questions and they can say, this is what I've heard. This is what I've read. Is there, can you give me some more background on that? And not to do that in a way that wags our finger at people or shames them, but honors the concerns that they bring to the table and recognizes that we are living through something that we haven't seen in 100 years, and the information is coming at us so quickly. So I think having conversation and asking questions, and then as people begin to see folks around them getting the vaccine and they hear their story, I think that's also really beneficial. So I think it's critical to have conversation, open conversation, and address those kinds of questions and the things that people are seeing and say, yep, that's exactly true, or there's a grain of truth there, or there is no truth to that whatsoever.
I'll chime in there as well. I think one of the key points that Neil mentioned was the ability and insistence on accepting why there is hesitancy, and really diving into, okay, I understand, and my parents having grown up in South Alabama and South Georgia in the 50s and 60s, I get it. I understand the ethical cases that this country, I used the word tragedy earlier, the tragedies that we've had along the lines of testing medications and vaccines on communities of color, and not recognizing the concern that still exists generations later. But also at the same time, realizing that those are real concerns, but we have still a really good opportunity here today to protect ourselves and protect our families, and try to take one step forward. So absolutely agree with Neil's perspective on that.
Thank you both for those answers. We've got another question that's asking, this is for Dr. Lamb, but Kyle, feel free to chime in as well. So how do you feel about employers requiring masks after the mandate is filled?
How do I feel about employers requiring masks once the mask mandate ends? I'll tell you from my perspective, and Kyle acknowledged this as well, PPE works. Masking and distancing works. And I think that the governor and the Department of Health have said, people, we know what we need to do. We know that masking has benefit. I'm thrilled that we have seen our numbers drop, our new cases drop. But I'm also very conscious that the majority of our population does not have immunity. They haven't gotten COVID to begin with, or they haven't been vaccinated. So if we all step away from wearing masks and from distancing, there's a whole lot of folks that are open targets for these new variants to make their way in. And so I know that people don't like wearing masks. I am not a fan of wearing masks and keeping my distance. But I think it is in our best interest to continue doing that. And I fully respect the right of groups and individuals to say, in our space, these are the rules that we're going to set up.
Well, I'll add just a tiny bit. One of our best charge nurses was actually contracted COVID from home and was our only employee that we lost to the disease. And I'll never forget how that felt to visit that family of that rock star nurse who meant so much to our team, and having the heaviness and gravity associated with making these types of decisions that could potentially, now of course it's not guaranteed, but could potentially expose patients, staff members, others to COVID unnecessarily because we want to stop wearing masks or we want to get back to normal. The gravity of that conversation with Jenny's family by far supersedes the discomfort that we have of going just a few more weeks, a few more months of wearing masks until we see that we're in that perfect place to begin relaxing some of those restrictions. So but it's a difficult seat. I'm sure as many employers, many organizations are going to have to make those tough decisions. But I fall back on Jenny and how we think about it here as far as what we decide to do going forward.
I know that people won't agree with Kyle and I, but for me, I think it is the highest form of Southern hospitality that I am wearing a mask because I am being considerate of those around me. You cannot tell if you are asymptomatic and spreading this. And I think anytime that I'm in a gathering of people, it could very well be me that is bringing COVID to the table. And so masking for me is about what I can do to keep those around me safe.
I'm totally borrowing that Southern hospitality quote. I've got to use that. That's good.
I was
It
just
is
gonna
yours.
say,
Take it and go.
I've never heard Southern hospitality defined in any other magnificent way. I think that is, especially during these times, something key for us to remember. And Kyle, I want to just, personally express, I'm sure as well on behalf of the city of Huntsville, condolences to Jenny's family and to your staff, having to go through that. So that actually kind of pours into the next question, because Neil, you mentioned being asymptomatic. One of the questions that we have in our chat it's actually a two-part question. First one being, is it recommended to test and quarantine before receiving a vaccine? And then the following question is asking, is there any danger should you receive a vaccine while being asymptomatic with COVID?
Kyle, do you want to speak into that? I can, but if you've got context, you probably have context that I don't have.
Sure, it's no problem. We've experienced both examples. I think we're at a point now we've vaccinated over 5,000 people, and of course, with that many individuals, you're going to have some who have who contract COVID during or between the two vaccine doses, or maybe even after the second one. So the experience we've had is a few, in fact, over 5 who received the first dose, either Pfizer or Moderna, and felt bad the next day and continued to feel bad and thought, this may be more than just a side effect. Were tested and were COVID positive. All of them know where they contracted COVID because a family member has since then become positive, and so on and so forth. Their regimen of vaccination remained intact, so they still waited 21 days with Pfizer and 28 days with Moderna, and then the 2 weeks after for full inoculation, and were fine, and all chose to continue down that same track to make sure they received their second dose on time. So just from an anecdotal perspective, our experience has been that it has not been an issue. But again, in those unique situations, you have to consult your physician and talk through what those potential risks are.
And I would just echo what Carl said. I don't think there's a reason to go get tested for COVID before you get vaccinated. I don't think you need to do that. And the CDC has said that if you've recently had COVID, then as soon as you're outside your 10 to 14 day window, when you feel better, go on ahead. You don't have to wait, with one really important exception. And that's if while you were sick, if you received antibodies, if you received monoclonal antibodies, then those antibodies can they can blunt your own body's ability to build its own immune response. So if you've received monoclonal antibodies while you were recovering from COVID, then you need to wait about 60 days before you start your vaccine process. But other than that, there isn't a reason that you need to wait. And if you got COVID between your first and second dose, that's fine. You just stay on course.
Thank you both for those answers, because it's also leading into kind of the hot topic that's currently going on, the vaccine, because we're always getting new information, and we're learning, of course, it's very important to stay updated in these matters. Now, one of the questions that we just received is, are there any varying types of effects based on blood type? And this is in regards to the vaccines. Is there any type of varying effects that you guys have seen or that we know of, maybe based on everyone's individual blood type?
So the data that I've looked at, and really early in the pandemic, like April of last year, we saw this really interesting finding that people with type O blood seem to have less serious complications than people with type A. And we didn't really understand it, but that effect has held up over time and over larger numbers. We don't have a good sense of exactly what that is, but I haven't seen anything related to the effectiveness of the vaccine as it relates to blood type. So, you're at a higher risk of side effects if you have this blood type, or you should take this vaccine if you have that blood type. I haven't seen any of those kinds of correlations.
Kyle, did you want to chime in for that one as well?
No, that's way out of my expertise. Perfect answer, Dr. Lamb.
No worries. Okay, so our next one is a little bit more specific. So they're asking, can the genetic information from the mRNA vaccination be manipulated once already within the immune system? And this goes for either one of you.
So I'm guessing that this is a question of, okay, if I get the mRNA vaccine, one of the mRNA vaccines, and the mRNA comes into my cells, can something happen with that somehow interferes with my own DNA? And the answer to that is no. So your mRNA doesn't go into your nucleus. The mRNA from the vaccine doesn't go in the nucleus where your DNA is. They're kept completely separate. And the mRNA has a relatively short half-life, a few days, and then it is destroyed. There are a number of things that would have to happen that don't happen typically in your cells in order for that mRNA to get into your nucleus, get reverse transcribed into DNA, and then inserted into your genome. So the mRNA vaccines don't modify your DNA. They don't make you a genetically modified organism, and they don't make you a transhuman. I've seen all of those storylines, and none of those are grounded in science.
All righty. Our next question is getting a little, well, so as you both mentioned that, recently now adults, or young adults we'll call them, that are 16 and up are now able to receive the vaccine. Which vaccine is safer for a 16-year-old? Does it make a difference?
Right now, there's only one vaccine that's available for a 16-year-old, and that's the Pfizer. The Moderna and the Johnson & Johnson are only for 18-year-olds. I think we'll see the others become available in the next several weeks or couple of months. But right now we've only got one that's been emergency authorized for approval. Kyle, you may want to speak into that more, especially since you guys have done so many vaccinations.
Sure. Yeah, we began with a shipment of Pfizer, and then had 3 shipments of Moderna, and now are getting weekly shipments of Pfizer. And you're absolutely right. I mean, there's a very specific instruction to make sure that the 16, 17, and 18-year-olds who are now eligible only receive the Pfizer vaccine due to the research that went into Pfizer for those age groups. So absolutely, only Pfizer.
And that really that speaks to the way they set up the clinical trials. Pfizer brought in those younger audiences that Moderna and Johnson & Johnson didn't. So it isn't that there's something wrong with offering it to younger people. They just weren't included in the initial clinical trials. And now we're seeing that. I'll say for what it's worth, my 17-year-old daughter got her first Pfizer dose last Saturday. So I have complete comfort and confidence in offering that. She teaches in an after-school program. After her high school days, she goes and works with 3 to 8-year-olds. And so we were very comfortable having her get the Pfizer vaccine.
And thank you both for putting the emphasis on, which one needs to kind of apply to each group. Because again, as we're getting new information, we want to make sure that we're kind of finding the correct paths that, relate to us personally or to our community. Now, this next one is set up like a true or false question. So this is for both of you guys, okay? So this person mentions, they kind of want clarification again, true or false. So is it true that the J&J vaccine is more like getting a flu shot and the PRM vaccine is more like a long-term vaccination with a booster? True or false?
I'm trying to think about, if I can only answer true or false, that boxes me in, and I like to live in the world of nuance and gray.
But we'll start with the first question then. We'll do it this way. So the first part of the question they asked is it true that the J&J vaccine is more like getting a flu shot?
So it is a one and done shot. And there are different kinds of flu vaccines that build immunity in different ways. But the Johnson & Johnson is a one-shot piece, and it can be a one-shot piece. It doesn't have to require 2 shots for 2 reasons. One, not only does this modified cold virus that's carrying the genetic code for the spike protein, it gets into cells, because the cold virus is really good at infecting cells, and it's been modified so that it doesn't make more of itself. It's just like a Trojan horse. So you've got the genetic code in, and the body starts making spike protein, but also parts of your immune system recognize that there's a cold virus out there around your cells. And so it turns on the alarm bells, which ramps your immune system up from the very beginning. So while you're making the spike protein on the outside of your cells and building immunity against it, you've got a higher response. It's like coming to a 4-alarm fire. So you get a much more powerful immune response right out of the gate. Unlike the mRNA vaccines, which the first dose really primes your immune system to say, hey, this is a little bit different. Start building an immune response. And the second dose is what triggers that higher level of alarm bells to give you a stronger, more lasting response. So there's some truth to that, but they are not the same. They don't necessarily use the same vaccination approach as a flu shot. Kyle, you may want to clean up all the things that I just said that might be really messy and murky in there.
I think no, I think it was excellent. The question seemed to indicate a desire to draw a parallel between the COVID vaccine and the flu vaccine, maybe regarding safety. And I guess we could both get into a box of saying they're extremely safe with regards to either type of technology that's driving the Johnson & Johnson, Moderna, or Pfizer. The safety has been proven out as it has for the flu vaccine.
The second part of that question was just kind of asking about the remaining vaccines. Are they similar to a long-term vaccination with the booster?
There is some similarity with that, although it isn't something that you have to come back and get a booster shot at 6 months or at 12 months. Part of the difference is those boosters give you much longer lasting protection. We don't yet know how long that protection really lasts with any of those vaccines, the Johnson & Johnson, Moderna, or Pfizer.
Thank you both for clarifying that information. We've got another question that just popped in. So this is in regards to the Johnson vaccine. Is the effectiveness less or more about the same? And this is again in regards to the Johnson & Johnson vaccine. And they're also asking, do you think the reason for low numbers of vaccinated in minority communities, could be due to the limited access of vaccines in the area? I know that you both talked about access in varying ways in your data. So that's another question that they had. So we'll start with the first one. So in regards to the Johnson & Johnson vaccine, would you say that, with the Janssen vaccine they put, is the effectiveness less or more about the same?
I'll take a first swing at this. I think because the Janssen and Johnson & Johnson vaccines are one and the same. I think the question maybe, which is what I've heard several times, is the Moderna and Pfizer vaccine less effective than the Johnson & Johnson vaccine? And I will put it this way. So working in healthcare, we're not, I think our CDC director used the same analogy. We're not nearly as concerned about mild cases of COVID. Although we want 0 cases of COVID, we'd much rather have a few mild cases of COVID than to have hospitalizations, ICU, mechanically ventilated patients due to COVID. all of the vaccines are extremely effective in preventing hospitalizations and ICU admissions due to COVID. Now, the Johnson & Johnson vaccine does have a lower level of effectiveness against mild cases of COVID. Although I think it's 70+%. I mean, it's extremely effective in the world of vaccine production. But yeah, the bottom line is we have to get to a place, and all of these vaccines will help us do it, to where if COVID is transmitted, then we have protection from our loved ones finding themselves on a vent in an ICU. That's the place we all want to get to, and they're all very effective in doing that.
I have nothing else to add. That was a perfect answer.
Okay, well, don't get too quiet on both on me right now, because this next question, Kyle, it's still kind of tied into the data that you shared, and it's still part of this first person's submission. So their general question is, do you think the reason for low numbers of vaccinated and minority communities is due to limited access to vaccines in their area? But I kind of want to rephrase that question and ask both of you guys. And Kyle, I know you had data and showed us that website with the varying numbers, literally a huge contrast that we could visually see. What do you both think are some of the contributing factors to low numbers for vaccinated members in minority communities?
I'll take another swing at that. I think both. So in our experience, we've seen, and personally, I've had Zooms with local pastors of predominantly Black congregations, to conversations with personal family members. That hesitancy that we've earned, I think, through our healthcare system through hundreds of years is real. And what we have found is that is, we can have, I can share data till I'm blue in the face. And I mentioned earlier, this is kind of my thing. I like getting into this stuff, and my family members know I'm really a geek about it. But when I present data opposing something that someone clearly knows their grandmother taught them about the Tuskegee study, that doesn't undo itself overnight. And as we mentioned earlier, and Neil point blank said, that we have to be respectful of that history and understand where that hesitation comes from, and continue to chip away at it and share those stories of folks who have been vaccinated, share the stories of providers who are from communities of color, and have them share their perspective on it as well. And over time, I think we'll get there. But it's, again, out of respect for the importance and the true history behind it, we have to continue to share the story. Number one. Number two, access is an issue as well. All of us public health folks realize that access drives many of our health disparities, and this is no different. And we've got to do a better job as healthcare providers to get out not only into communities that seem to be profitable, but also directly provide access to, even deliver services in the community of color, and making sure that those folks have equal access to life-saving services as anyone else in any other aspect of our community. So yes, it's both access as well as hesitancy is driving some of those numbers.
I think that what Kyle said just speaks to that so well. You start with a foundation of hesitancy from very well understood and with clear examples of why you have that hesitancy. You don't even have to go back to Tuskegee to see, today you see those issues. And then you layer on top of that, okay, well, let's say that I've overcome that. Now, how do I even find where I can get a vaccine? And how can I find a place where I can actually get an appointment that's not in June? Okay, so that means I've got to work my way through the internet in many cases, and I've got to watch lots of different places, and I need to manage checking lots of different sites. And then once I find a spot, do I have a way to get there? Is it a convenient time for me? Do I have to take off work in order to get there? And then, except for the Johnson & Johnson vaccine, I got to do this again 3 or 4 weeks later. So it's It's just layer after layer of challenge. And some folks might not even see that as a challenge at all. I went online, I had the, I found a time, I found a spot, I drove 50 miles away and I got it. It was easy. It was at, 11 o'clock in the morning. But I've just given you like 5 reasons why individuals that don't have transportation, that aren't internet savvy, that can't just leave work, why, all those things, that's just totally taken them out of the picture.
Well, and not to add on, but I mean, I think this is something that we all, the responsibility, and I want to make sure I'm clear about this, of getting those services to every community rests on healthcare providers. We've got to do a better job. All those examples that Neil mentioned of, we'll call individuals who are on our waiting list and say, hey, Mr. Johnson, we know you've been waiting on our list for a month. We have an appointment for you next week at 9 o'clock. Well, Mr. Johnson works at 9 o'clock and is 3 counties away because he signed up for every list he could because he was so desperate to get this vaccine because he wants to see his grandchildren. All of those elements play into what historically hasn't been a responsibility that healthcare providers have said, we have the responsibility to get our services to them, not they have a responsibility to get to us. And that whole paradigm shift is tilting now in a more critical time than ever on this vaccine distribution. And we've got to do a better job at that.
And all of what both of you guys are saying, really pours into kind of the overarching theme that we have with all the presentations we've had, with diversity, equity, and inclusion, because we're talking about everyone needs to have the vaccine so that we can all, balance out and flatten the curve. But as you both have talked about, there's almost a process, even if you want to call it, just to get a vaccine, whereas everyone's striving for the same thing, but there may be different obstacles or hurdles that we may not see or someone else may not see based on their perspective. And another thing that you guys talked about that's very important is, Kyle, I think you said it best in terms of kind of like not forgetting the history that may play a part in certain communities. And that actually rolls into another question that we have. So if we talk about minority groups, especially not forgetting history, we think of someone like Henrietta Lacks, who cervical cancer cells contributed to large medical breakthroughs. So the question that this next individual has is, what is being done to ensure that more people of color can participate in clinical trials? Because again, understanding the importance in the process of confronting I'm sorry, I'm trying to read this correctly. Oh, basically finding effective ways to defend ourselves against infectious diseases, primarily, of course, COVID-19. But in talking about history, being aware that someone may not have the same access, what can we do, or what can we begin to discuss about ways that help people of color have access to these efforts or access to vaccines?
I can start with that. We have done a really poor job, especially in genetics in my field, of building databases that are diverse. And so many of our databases, our health-related databases, are from white individuals. And it's really difficult, number one, to always say, well, that data that worked in this population clearly translates over for what we need to think about in other populations. Often it does, but not always. And you also miss out on incredible findings that might be present in a specific group that if you don't ever bring them to the table, you never see and nobody ever benefits from. So we've done a poor job of that. And I know that with these clinical trials for the vaccines, there was a very intentional push. The FDA said, you need to do everything you can to enroll individuals from a diverse background, especially those that are traditionally underrepresented. And with the clinical trials, you didn't see the diversity matching the diversity in the population, but I think you saw the most diverse clinical trials to date. So there was a win there. I would say that here in our community, there's a great company, Acclinate Genetics. They've got a presence here in Huntsville. They're growing a presence in Birmingham, and they are dedicated exactly to what you just said, Tiffany, which is how do we increase participation of underrepresented populations in clinical trials? How do we ensure that more people have a voice in where the science goes and what it's telling us, and so that when they're offered medications, they can see that people like them have been involved in the testing and have had a voice and have been able to speak into that.
Ditto. Amen. All the above.
I had just unmuted myself because I thought Kyle was coming with something next and profound, and then ditto is the profound word of the day. There we go. So we've got a couple more questions, and folks, thank you for submitting your comments. We are here until 2 o'clock. So again, if you guys have any other questions, feel free to submit them through Hoover. I am monitoring the comments and the chat. So we talked about progression. We talked about different perspectives. We've talked about a big thing that I think we can take away, that being access. And I think the other catchphrase being Southern hospitality and what that means in a pandemic. So kind of steering away now from the vaccine, another question that we have is, do either of you have concerns with the expiration of mask ordinances? You know, Neil, you've been very transparent and said, you know, we don't like wearing masks or social distancing, but with there kind of being no perceivable end to mask ordinances, again, this question is to both of you guys. Do you have any concerns with the future expiration of mask ordinances?
I'll jump in this one. We have, well, let's go back a year. So a year ago, we had, and Neil showed you the graph of both of the summer surge and the winter surge that we experienced. We attribute those to transmission throughout the community. The first surge we had was in the summer and was met with a new mask mandate, which I'll be very honest, I mean, we heard so much concern throughout the community about it, but we saw a precipitous drop almost overnight. And in my world, over a couple of days, I mean, we saw a significant decrease in COVID transmission when the mask mandate and the stay-at-home order were implemented. Never thought we'd be still here in almost a year, but it worked, quite frankly. It absolutely worked. Are we at a point today where I feel like we can take these steps as a state in all of our communities that are having different experiences and just throw our masks away? Absolutely not. We've seen within our hospital and across the community where masking has absolutely been a key part of how we've survived this pandemic. I'll say this, even during the mask mandate, indoor family gatherings between Christmas and, well, Thanksgiving, Christmas, and New Year's of 2020 is precisely what we attribute the huge, almost back-breaking surge we encountered this winter. So I would say two things. One, yes, the mask mandate ends Friday. I understand where the governor is coming from in trying to move forward. I think she was smart to emphasize that that organizations may continue to require it, and also individuals should continue wearing their mask regardless of what the federal, state, or local mandates are. So that those components all go into the mask part. But I'll be very frank with you, mandate or no mandate, huge indoor gatherings, and again, we saw them last summer lead to a surge. We saw them last winter lead to a surge. We have to be smart about those activities in addition to continuing to choose to wear our masks and continuing to have those smart initiatives in place. But yes, it's we're at an inflection point that we could really be smart about this and drive these vaccines and do the protective measures and completely squash to a very minimal level this pandemic, or we can allow it to linger by not doing the things that we know work. And again, that's mandate or no mandate, we have to do what works.
Kyle, I really appreciate the way you just framed that. Like you, I'm deeply appreciative that Governor Ivey had 9 months of a mask mandate. I think that has been really beneficial. My masks are not going away. They're not going anywhere. I'm not going to have a mask burning on Saturday morning. In fact, at Hudson Alpha, where I work, we'll continue the mask mandate. And we're getting ready to start registration for our summer programs, our middle school and high school camps, and our on-campus programs. And we're all going to be masked throughout that, especially because we're working with younger audiences that don't have access to vaccines. So in the early days of the pandemic, one of the phrases that I used a lot was that we hold the future, we hold tomorrow for our community in our well-washed hands. And so the actions that we take today shape what will happen in our community tomorrow. And I really hope that future Neil of September 1st, 2021 doesn't say, wow, we just went through a horrific summer surge. We know what we need to do. It's now our responsibility to do that. I think it is really important to continue that process.
So as we approach the end of our panel, you guys are hitting on the final topic, when we discuss the future of Alabama, future Neil, future Kyle, future everyone that's on, that's watching this at this moment. We have a parent that's asking, and talking about the future, the next generation, so young kids. Do either of you foresee where this will become a required vaccine? So if we think about mumps or chicken pox, but do you guys think that this will be a required vaccine in the future?
I think it depends on what happens this summer and fall. This is, and again, I have to continue to remind myself and others, this is a completely new virus that we're moving, not to use an overused term, but at warp speed to try to catch up with and eradicate. So I don't know if, and Neil may have more insight, I think at this point, time will tell long term if this is an annual vaccine that becomes just a part of how we have eradicated mumps and measles and chickenpox to a large degree in an annual way. I think, quite frankly, if I were betting, I would imagine that it will be, but only time will tell.
Yeah, I agree. It's too soon to know. And that's a deeply unsatisfying answer. We have lived through a lot of uncertainty right now, and we would like black and white answers, and we don't have those. It's possible that the virus will just kind of become something that we see seasonally, like flu. It's possible that this is something that is going to stay a pretty high concern for several years, and we continue to get vaccinated. It's possible that the virus mutates even more, and now it becomes something more concerning, and we have to think about a completely different kind of vaccine. We just don't know.
And that feeds into kind of this ongoing rolling period that we're in, where every day, can be new information. And so that's why having panel discussions like this are really, really important. And I, again, want to thank both of you guys for taking the time to used me to speak directly to the community, and community, thank you for submitting your questions, to these medical professionals, because if there's anyone to ask these questions to, it would be either one of these gentlemen. So we're down to our final 5 minutes. And again, thank you, community, for submitting your questions. I do see the chats and everything coming in, but we're going to wrap it up because we're down to our final few minutes. So major question for both of you guys. I know that we've discussed the vaccine. We've discussed ways that we can be involved and kind of help communities that might not have the same opportunities, and definitely shown data that shows where we as a community need to do our work to participate. But now, outside of the vaccine, social distancing, and masks, is there anything else that you feel that we can individually do to help the Alabama community, just improve? And like you said, this time next year, this time next summer, not see what we're seeing today?
So Kyle touched on some really great points. The mental health crisis that I think is at our door. We've had a lot of people that have lived with anxiety and fear and grief. And as the immediate concern begins to pass, and we're certainly not out of the woods yet, but I think we're going to see more of those things. We've got a whole set of school kids, some who have thrived in an online setting, but a lot of kids who haven't. And so how do we support them? How do we help them get what they need to move forward? And I think the last thing that I would say, we have to continue to unpack our patience. We are not finished with this. And it's possible that we may have several more weeks where we're going to play this. Okay, I'm going to get up and I'm going to look at today's headlines. And what is that? Do I have a pit in my stomach, or am I enthusiastic about where we're going? So we just have to wait and be patient, and we have to give each other grace and kindness. And I know that sounds like I've now just suddenly wandered off into la la saccharine land, but I think giving a little more space to our community, to our neighbors, to the people that we run in with, we're all coming out of some really challenging times, and we will continue to move through this as a community. And until everybody has access, until everybody has care, we don't live up to the potential of what we could. So I think for me, it's unpack our patience and be prepared to deal with longer term effects.
I couldn't agree more with those points, and I'll add a couple to it. And I guess I'll go to La La Land as well. We have a unique opportunity to be more sharing with those around us. We talked about vaccine hesitancy and concern and real issues and tough conversations to have. Being open and sharing those experiences, sharing those concerns, and talking through them as a community, as a family, we found to be one of the most effective ways to move the ball forward. We saw that when COVID first hit, and we had folks say, hey, you should share your experience about contracting COVID and your family member. Now we're having the same sharing conversations about the vaccine. Then also reaching out and going back to mental health, we've got to start reaching out and being more forthcoming regarding our challenges throughout our communities. Mental health is a big one, but also when we look at economic opportunities, reaching out to each other others who may have not been given access to particular opportunities, finding ways to do that and finding ways to engage with new communities and really building those bridges that may have never existed before, but now we've got a good excuse to do that across the board. But yeah, the sharing and the reaching out that has proven to be effective. Let's continue doing that in unique ways.
Thank you again to both of you guys for sharing your knowledge, your expertise, giving us data, information, and I think even more importantly, giving us next steps on what we can do as homework, within the community to really help our neighbor, help one another, and kind of to what both of you guys mentioned, not be in the same space next year. So everyone, I want to thank you for coming because we are right at 2 o'clock. If you guys want to find more information, you guys have already registered through diversityhsv.org. But I also want to mention that if you like to learn more information, you can check out acclinate.com, where you can learn more information about diversity and inclusion in clinical trials and learn how to become a part of their Now Included movement. That's one of our panelists that wasn't able to make it today, but we do want to make sure that we also check out Acclinate. And again, that website is acclinate.com. But Neil and Kyle, thank you both for representing your organizations and speaking to the community. Thank you everyone for your time, and have a great day. And if you're in Huntsville, stay dry. Thank you, everyone.